This educational COVID-19 intervention strategy presentation will discuss the evidence-based recommendations for managing acute COVID symptoms and how to promote up-to-date practice in the workplace. 3/4 of this presentation will discuss actual guidelines and recommendations, while the latter quarter will bring up the issue of variance among hospital policy and potential corrections the critical nurse can advocate for. Due to the ever-changing nature of COVID-19 research, some of this information may be out of date at the time you're listening. This presentation was created, edited, and recorded by myself, Noah Dagan, in June of 2021. To understand the recommended treatment modalities of acute COVID symptomology, we must first look at what defines and what is commonly found in acute COVID diagnoses. The CDC notes that treatment for severe disease will surpass self-care and basic medical interventions like oxygen therapy via a nasal cannula and intermittent pulse oximetry checks. The progression to severe disease often results in an admission to intensive care. The common laboratory findings in the acutely ill COVID patient include reduced T, B, and natural killer cells, inflammatory-induced neutrophil formation, elevated ALT, AST, and C-reactive protein levels, and increased levels of the intracellular iron storage protein, ferritin, indicating increased red blood cell formation. Knowing the purpose behind these laboratory findings is imperative to the critical care nurse as they relate to disease severity. From these findings, and many others, one may track the progression of typical COVID complications such as pneumonia, acute respiratory distress syndrome, sepsis, and acute kidney injuries. The National Institute of Health, or NIH, recommends to treat COVID and hemodynamic instability with the same interventions as sepsis. This is commonly done through dynamic assessment tools like a passive leg raise test or a 250 to 500 milliliter fluid bolus over 15 to 30 minutes. The subsequent adjustments to vasopressors and or IV fluids has been reported to decrease ICU length of stay by about a day and time on mechanical ventilation by about 3 hours. The use of balanced crystalloids, such as lactated ringers or plasmolite, which are more similar to serum plasma, consistently prove to outperform the use of unbalanced crystalloids, like normal saline, in the septic patient. Higher concentrations of sodium and chloride in normal saline eventually damage the kidneys and other sensitive organs, which prolongs care. The World Health Organization, or WHO, recommends Levophed as a first-line vasopressor to maintain a mean average pressure of 65 or greater. This should be titrated to the lowest possible dose to reduce potential side effects while still maintaining organ perfusion. The NIH and WHO's recommendations for ventilator avoidance and goals for oxygenation begin with the non-intubated patient in acute hypoxemic respiratory failure. These guidelines also stem into the non-COVID patient as well. One study compared the use of conventional oxygen therapy, high-flow nasal cannulas, and non-invasive ventilation like CPAP and BiPAP to determine risk factors for eventual intubation. It was found that the average days off of ventilation in a critically ill patient's stay were greater with the use of high-flow nasal cannulas prior to intubation. In addition, the likelihood of being intubated was higher in both conventional oxygenation therapy and non-invasive intubation by a hazard ratio of 2.07 and 2.57 respectively. Hazard ratio being the chance of an event occurring based on dividing an independent variable and dependent variable. This research shows that high-flow nasal cannula oxygen therapy produces significantly more favorable outcomes than conventional oxygenation therapy and non-invasive intubation. In a prospective feasibility study of 56 acutely ill COVID patients, researchers looked at how proning affected their PF ratio. PF ratio is a non-diagnostic tool for worsening hypoxemic respiratory failure. With PF ratios below 300 indicating hypoxic respiratory failure, the study showed how proning, for around 3 hours, can close the gap towards more normal levels. The study also found, however, that the PF ratio dips back down to baseline after resupination. Despite these findings, the NIH and WHO recommend proning acutely ill COVID patients so long as there is no risk for intubation. For the COVID-19 patient with acute respiratory distress syndrome, the NIH and WHO recommend multiple mechanical ventilation care strategies. Tidal volumes of 4 to 8 milliliters per kilogram are preferred over 8 milliliters per kilogram due to reduced lung compliance. Lower inspiratory pressures or plateau pressures, as well as higher positive end expiratory pressures, known as PEEP, prove to support reduced lung compliance as well. Similar to the non-intubated acute hypoxemic respiratory failure patient, PF ratios indicate a need for proning. In the acutely hypoxemic respiratory distress syndrome patient, however, proning is needed for 4 times as many hours. If the condition of these acutely symptomatic COVID patients continue to worsen, despite conservative fluid strategies, the NIH recommends the use of neuromuscular blocking agents, like vecuronium or rocuronium, for up to 48 hours to assist in vent desynchrony issues. Above all else, ventilator disconnection for any amount of time should be avoided, as the immediate loss of PEEP and atelectasis formation places the patient at risk for desaturation. There is also a significant increase in the risk for healthcare worker infection. According to a large study of over 5,000 COVID patients in New York City, 22% of patients admitted to the ICU required continuous renal replacement therapy, or CRRT. Because of COVID-19 and risk for healthcare worker exposure, CRRT is preferred over prolonged intermittent renal replacement therapy and standard hemodialysis, as it only requires hourly adjustments as opposed to constant monitoring. To the right, you can see one of the most common types of CRRT, which uses dialysate as a way to create a pseudo-urine known as filtrate. The use of remdesivir as a broad-spectrum antiviral remains recommended by the NIH in the treatment of acutely symptomatic COVID patients. It may be used in adjunct with the monoclonal antibody tocilizumab, so long as it is combined with the corticosteroid dexamethasone. One class of medications used for inflammatory and autoimmune diseases is known as a Janus kinase inhibitor. The only recommended medication in this class is baricitinib, which must be given with remdesivir and never dexamethasone. Other drugs that the NIH and FDA recommend against or have disapproved include colchicine, an anti-inflammatory drug, convalescent plasma, and the anti-malarial hydrochloroquine, as not enough clinical data has been gathered at this time. For more information on antiviral and other medications recommended against, please see the most recent NIH COVID-19 treatment guidelines. In the spirit of healthcare provider awareness, I'll be discussing one hospital's COVID-19 treatment guidelines. Information will be presented objectively. This is to be used as a learning opportunity for critical care nurses, as our focus is more commonly placed on the patient rather than updated hospital policy. However, as direct care providers of this vulnerable patient population, we must attend to advocating for the adherence of up-to-date evidence-based practice suggestions. For example, at the time of this recording, the treatment considerations in adults and children with laboratory-confirmed COVID-19 at Munson Medical Center was last updated 83 days ago on April 7th, 2021. The recommendations made in this document regarding the necessity of combining dexamethasone with tocilizumab and other drug considerations are present and accurate. Full awareness to the care provider is made regarding what drugs are recommended against and for the acutely symptomatic COVID patient. There is, however, a complete lack of guidelines regarding hemodynamic management, oxygenation and ventilation guidelines, common laboratory findings, and acute kidney injury and replacement therapy. At the end of this presentation, you should ask yourself, does my hospital update guidelines as new evidence-based information is being presented? Is there an area of practice not discussed or fully covered that could be improved? And is this information even easily accessible to me as a practicing healthcare provider? As nurses, we assume responsibility for the advocacy and care of individuals who are unable to do so on their own due to a compromising clinical condition. Would we ourselves not want most up-to-date care strategies used on our families who may potentially be or already have been in these situations? The obvious answer of yes to this question should motivate us enough to investigate whether the policies we work under are accurately set in place. If the care we are providing is really what is best for our patients, our community. My hope with this presentation is to advocate to nurses to spread evidence-based research to their clinical team managers in order to follow the most up-to-date practice guidelines. I appreciate the time you spent listening, and please feel free to share with anyone who you think may be motivated to advocate on any of the information presented here. Again, thank you.